Thank you very much. It's great to be here, though it's always tough standing between folks and lunch. But I appreciate the opportunity to share our work in gene therapy. PTC Therapeutics is a global diversified biopharmaceutical company that discovers, develops, and commercializes therapies for rare disorders. We were founded about 25 years ago with the explicit purpose of using innovative science to treat patients with rare diseases. Over the past 2 decades, we've grown quite a bit. We now have over 1,200 employees and a commercial footprint in over 50 countries, yet we remain true to our founding mission, which is to use transformative science to develop important therapies. We have a diversified rare disorders portfolio that's built on a number of different platforms, each of which is based on innovative science and novel approaches to drug delivery. We have a number of marketed products, including our products for Duchenne muscular dystrophy, as well as our recently approved gene therapy, Upstaza, which I'll be referencing in just a minute, and a broad pipeline with a number of different programs at varying stages of development. But of course, today the focus will be on our gene therapy platform, including Upstaza, which was approved in July for the treatment of AADC deficiency. PTC's strategy for gene therapy is targeted delivery. That is, delivering the gene therapy to an anatomic location key to a particular disease. This approach has several important advantages. First, it ensures that the therapy gets to the right location in sufficient quantities to have a significant effect. This is particularly important for treating disorders of the CNS, so that rather than relying on administration peripherally or intrathecally, we're sure that we can directly deliver the therapy into the right location in the brain that is key to a disease pathology. Also, by doing local administration, we are able to have lower dose levels, which reduces systemic immunogenicity and exposure risk, and also has the advantage of lowering manufacturing burden and ultimately patient burden. When you think about the dose of our Upstaza therapy, it's at 1.8 times 10 to the 11. That's 1,000 to 10,000 times lower viral load than with some systemically administered gene therapies. And finally, by directly accessing cells in the brain of low turnover, like the neurons, we're able to have therapies that are durable, which is something you'll see when I talk about our AADC program. So now let me talk about AADC. AADC deficiency is a monogenic disorder that results from defects in the enzyme responsible for the production of dopamine. Essentially, the AADC enzyme is responsible for the conversion of L-DOPA to dopamine. The lack of this enzyme results in profound depletion of dopamine levels and profound dopamine motor defects, given that dopamine is a neurotransmitter responsible for most of our motor function. Children born with AADC deficiency never achieve many of the typical motor milestones that other children would achieve, such as the ability to crawl, to sit, to stand, to walk. And this disorder is highly morbid and usually fatal in early childhood. Typically, these children have failure to thrive, get recurrent respiratory infections because they can't manage their secretions, and again, tend to die in early childhood. So a quite serious disease. Our gene therapy, Upstaza, also known as Eladocagene exuparvovec, a little more complicated name, is a recombinant AAV2 therapy that basically provides a working copy of the AADC gene. And given the fact that we're replacing the entire gene and providing a functional copy, it's able to provide benefit to patients regardless of the specific mutation that they may have in the AADC native DDC gene. Upstaza is delivered directly into the brain. It's directly administered into the putamen, which is the anatomic location where the dopaminergic neurons are located. So this is an example of saying, here's a disease that results from depletion of dopamine. The dopamine neurons don't see dopamine, don't function, are not able to coordinate motor function. And so what do? We put the gene therapy right there in the putamen, so as enzyme production starts, dopamine production can occur, and resumption of motor development can then occur. Again, there's many advantages to doing this direct administration. Importantly, we're sure that enough of the therapy gets to the right location. We don't have to worry about getting through the blood-brain barrier or giving high enough doses to achieve biodistribution to the regions that matter. And again, by having these lower doses, it absolutely lowers the risk to the patient, obviously lowers the risk of systemic immunogenicity, and again, by directly administering the therapy to the neurons, we're putting them into low turnover cells and are able to get durability of our response. I should mention the therapy is administered through a stereotactic surgical approach, which is basically using a Google map that directs the surgeons to go right from the outside of the child's head directly into the putamen. We first gauge therapeutic response using a dopamine PET scan. This provides objective evidence of successful gene transduction as well as successful production of dopamine. And what you see here is a summary of our data from a number of our clinical trial patients where we're able to demonstrate very low levels of dopamine prior to treatment, then increase in dopamine levels that is maintained out past 5 years in all the patients that have been treated and assessed that far. So this tells us several things. One, the gene's getting to the right place, the gene's allowing for the production of dopamine, and then, as I mentioned, by putting it into low turnover cells, we're able to get durability of effect, having evidence of successful transduction and dopamine levels maintained several years after therapy. When we look at the clinical benefit, we see exactly what you'd expect if you were able to provide for dopamine production. That is now the ability to gain those key motor milestones that are lost as a result, or actually never gained as a result of not having dopamine. We had 30 patients treated in the clinical trials that form the basis of our MAA approval in Europe. And what we see is that motor milestones are occurring in the majority of patients, and we have several patients now that have gained the ability to walk. I'll point out that what we've seen with the children treated is that they gain motor milestones sequentially over time and at different rates. There are some children who will rapidly gain the ability to crawl, to sit, to stand, and to walk. Others, it may take several years. So what you're seeing is just a snapshot of many different patients at different stages of time. And as we continue to follow these children, we fully expect more of them will be gaining the more complex milestones of being able to stand and to walk independently. In addition to the improved motor function and neuromuscular function, we also have documented a number of other significant improvements in these children, such as improvement in language and cognitive skills, as assessed by the Bailey Development Tool. We've also seen a reduction in the occurrence and duration of what are called ocular gyrocrises. This is a key pathological feature that resembles a seizure that's common to children with AADC deficiency. We've also seen improvements in disease morbidity, with improvements in weight gain now that the children are able to feed through the ability to coordinate their swallowing and also have normal gastrointestinal function. We're also seeing a reduction in the number of respiratory infections, which obviously is important given that this is the key risk for mortality in this disease is related to having severe recurrent pulmonary infections. We also have been gauging treatment response through a number of other biomarker studies in addition to the dopamine PET scans, including looking at homomethylenic acid in the CSF, which again is another measure of de novo dopamine synthesis following treatment. And importantly, the gene therapy is demonstrated to be safe and well tolerated with very limited evidence of any viral shedding and no drug-related serious adverse events. If a picture is worth 1,000 words, then the videos I'm about to show you speak volumes. They tell the story of the severity of this disease at baseline and also provide very clear evidence of the transformative effects of the gene therapy. I'm going to show you 2 videos, and this first video is of a child. This is him 2 years of age prior to gene therapy. You'll see he has no spontaneous movements. He's feeding tube dependent. Now 1 year after therapy, we start seeing him have spontaneous movement, the ability to crawl, also having purposeful movements. I'll point out that he's wearing a helmet just because it was a safety precaution that his parents put on a helmet on him as he's learning to navigate his environment on his own for the first time. We now see him being able to stand And now 2 years after therapy, we start seeing him be able to walk. This is very typical of the gradual acquisition of milestones we observe in patients over time. Now 4 years after therapy, we see him being able to walk independently, and quickly down the hallway, run away from mom. 5 years after therapy, we see him able to continue to walk and run, and walk upstairs. I'll point out that the natural history of the disease, like other neurotransmitter diseases, is not this. You don't gain the ability to make neurotransmitters. These children do not spontaneously gain the ability that this child demonstrates. Here's another child. Here she is at 19 months of age prior to gene therapy. Again, you'll see a flaccid child, no spontaneous movement. Feeding tube dependent, no purposeful movements, respiratory support needed. And here she is 7 months after therapy, already being able to sit up, stand. Again, evidence that these children may acquire milestones at different timing. Hand-to-mouth coordination, obviously purposeful movement. Here she is 2 years after therapy, standing and playing, seeming to be very much like a child with normal motor development. Here climbing up in the playground, walking and kicking a ball. Again, climbing stairs. Here she is learning her alphabet and reading. And she's basically sharing her name. Her mom and dad are asking what her name is. So very much looking like a child who has developed normally in terms of developmental milestones. So again, clear transformative effects of this gene therapy that would not be occurring without treatment. So we have gained approval for Upstaza in Europe in July 2022. Launch is underway, and we're in the process of preparing for a BLA submission in the United States. In addition to our program for AADC deficiency, we have a number of gene therapy programs in the pipeline. Our two lead pipeline programs are for Friedreich ataxia and Angelman syndrome. Again, diseases, rare disorders of high unmet medical need that may be amenable to direct administration. We also have the benefit of now leveraging a number of key important learnings from the successful development of Upstaza for AADC deficiency, both in terms of preclinical elements of development as well as the clinical development program. Just a quick word on Friedreich ataxia. This is a severe neuromuscular disorder resulting from the frataxin mutation. This is a disease has a number of different clinical signs and symptoms, many of which are neuromuscular, particular ataxia. Friedreich ataxia, the ataxia component comes from degeneration of the dentate nucleus in the cerebellum. There's a number of other non-CNS manifestations, but what we're focusing on in the gene therapy program is the cerebellar portion of the disease, where we deliver the AAV FA gene therapy directly to the dentate nucleus of the cerebellum, again using a stereotactic surgical procedure. And the idea here is, given the importance of this anatomic region to a core aspect of disease pathology, we believe we can provide significant benefit through providing gene therapy and a working copy of the frataxin gene to patients with Friedreich ataxia. We look forward to moving this program into the clinic in the very near future. Finally, as I mentioned earlier on our panel on commercialization and others have talked about today, we have taken manufacturing matters into our own hand as well, opening up a gene therapy manufacturing site in Hopewell, New Jersey. It's a 220,000 square foot facility capable of both development and GMP manufacturing of both plasmids and AAV vectors. We have up to 1 liter capacity now. We have full bioanalytical support, a highly expert team, both from a manufacturing standpoint as well as a quality and bioanalytical support standpoint. This is allowing us to really accelerate the development of a number of our gene therapy programs, and given that we have this existing capacity, we're also able to serve as a CDMO for other companies trying to find a site for plasmid and AAV manufacturing. Thank you very much.